Rahim. Assalamu alaikum. Today's lecture is a rather an important topic in medicine, and that is the subject of heart failure. Heart failure, often called congestive heart failure, and this occurs when the heart isn't able to pump enough blood. As you know, the heart is a pump. Okay, this is its main function. There are many classifications for heart failure, but this one is very popular. According to this classification, we classify it into systolic dysfunction and diastolic dysfunction. Systolic dysfunction occurs when the heart is unable to pump enough blood, and diastolic dysfunction occurs when the heart is unable to accept all the returning blood to the heart. There is a functional classification of heart failure. Again, this is quite popular, the New York Heart Association classification. In class 1, there is no limitation in unusual activities. In class 2, there is a slight mild limitation of activity. The patient is comfortable at rest or with mild exertion. In class 3, there is marked limitation of any activity. The patient is comfortable only at rest. Class 4, any physical activity brings on discomfort and symptoms occurs at rest. A second classification is the American College of Cardiology, American Heart Association classification. This classification is staged as A, B, C, and D. In stage A, the patient is at high risk for developing heart failure in the future, but no functional or structural heart disorder. What does this mean? This means if the patient has a reason or a cause for heart failure, then he is in stage A, although he is not yet in heart failure. For example, a patient who had myocardial infarction is stage A, although he is not yet in heart failure. Or a patient who is hypertensive, okay, or a patient who has valvular heart disease, etc. In stage B, a structural heart disorder, but no symptoms at any stage. And what does this mean? This means that when you examine the patient, you find an evidence of structural heart disorder, but the patient is asymptomatic. What are these structural heart disorders? For example, when you examine and you put your finger, you may find that the apex beat, which is normally just palpable, is a thrusting in nature, i.e. pushing your fingers away. And I hope in our clinical teaching, we will discuss to you what does mean a thrusting apex beat means. So if the apex beat is a thrusting, then there is structural heart disorder, but the patient is not yet symptomatic. If on the ECG, there is left ventricular hypertrophy, again, this is a structural abnormality, but the patient may be asymptomatic. This is again stage B. On the chest X-ray, if the left ventricle is enlarged, on the echocardiogram, if the ejection fraction is low, but the patient is not yet symptomatic. Even if you look into the retina of the patient, of a hypertensive patient, and you see retinal arterial changes, but the patient is asymptomatic, this will classify the patient or will stage the patient as a stage B. In stage C, there is previous or current symptoms of heart failure in the context of an underlying structural heart problem, but this is managed with medical treatment. So the patient may be on some form of anti-failure treatment, but he's doing well. This is stage C. Stage D, advanced disease requiring hospital-based supportive or heart transplant or palliative care. Okay, so this is in a stage D when the patient is in bed, the patient is short of breath, the patient has reduced usually ejection fraction on the echocardiogram, the chest x-ray probably is enlarged, and some of these patients, if they are young, they, if available, they should have heart transplant, or they go on palliative treatment. Okay. What are the main causes of heart failure? Coronary artery disease in most developed countries now on top of the list. Okay, 30 years ago in North America and in Europe, hypertension was on top of the list. Now hypertension is second to coronary artery disease, but I believe in the Middle East, still hypertension is the first. Okay, so coronary artery disease, hypertension, valvular heart disease, cardiomyopathy, and cor pulmonale. Cor pulmonale, by the way, is heart disease secondary to lung disease. You will have a separate lecture on this subject. What are the causes of congestive heart failure? Actually, this is another study which I think is rather interesting. That's why I put this slide. According to this study, ischemic heart disease account for 62% of heart failure. Cigarette smoking accounts for 16%, and this is cigarette smoking irrespective, I mean cigarette smoking per se. You know that cigarette smoking, for example, can cause cor pulmonale, it can cause ischemic heart disease, it can cause hypertension. But this is cigarette smoking without any of these is responsible for 16%. And if we count ischemic heart disease and other problems, then it will be much more. Hypertension is responsible for 10 cases of the heart failure cases, obesity 8%, diabetes 3%, and valvular heart disease 2%. Valvular heart disease is much lower down. Valvular heart disease years ago used to be very common, and the reason for that is that rheumatic fever is an extremely rare condition now. It was very common years ago. Now, what are the symptoms of heart failure? First of all, fatigue. Fatigue is not a very distinct term. Okay, if you go upstairs, then definitely you will feel fatigued. Okay, but leave it to the patient. If the patient believes that the degree of fatigue he is encountering now is unusual, then this fatigue is not the normal or the physiological fatigue we have. This means that this may be the earliest symptom of heart failure. The second symptom is dyspnea, and dyspnea is probably the most prominent symptom of heart failure. In dyspnea, you have to familiarize yourself with the following terms. Orthopnea. Orthopnea means when the patient lays down, then he'll get short of breath. Paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea is shortness of breath, occurs usually in the first 2 hours after going to sleep. So if a patient goes to sleep at 10 p.m., then he or she may wake up in the middle of the night, gasping for air. And once they are up, they'll run to the window trying to get the fresh air. Then the dyspnea will ease and it will vanish. This is paroxysmal nocturnal dyspnea. I remind you again, paroxysmal nocturnal dyspnea usually occurs in the first 2 hours of sleep. The second one is Chinese talk respiration. What is Chinese talk respiration? Chinese talk respiration is this. Just watch me if you see me. The patient takes a deep breath. Did you notice this if you are seeing me? So what happened is that the patient will take a breath, and then the second breath, there will be a little bit of delay. And in the third cycle, the delay will be longer. Then there will be a long pause, and then the patient will start taking a quick breathing. This is called Chinese talk respiration. This occurs with heart failure, but it occurs with other diseases as well, with respiratory diseases and with central nervous system disease as well. Acute pulmonary edema is another term. This is usually seen in casualty. If you are sitting in casualty and you get a 68-year-old man, hypertensive probably for 20 years, and all of a sudden he gets very short of a breath, and usually he'll get panicky, and the family will bring him gasping for air. Most probably this is acute pulmonary edema, and I'll show you chest x-rays of patient with acute pulmonary edema. The other symptoms are gastrointestinal symptoms: anorexia, nausea, early satiety, and abdominal pain. All these may occur with heart failure because of congestion of the liver and gastrointestinal tract. And very often for these reasons, the patient may lose weight. Okay. The other symptoms are cerebral symptoms: confusion, disorientation, sleep, and mood disturbance. Now, we should go for investigations. How do we investigate a patient with heart failure? Actually, usually you should start with very simple investigation which are available. And what is available for you if you are sitting in casualty? ECG and chest x-ray. These should be the first one, the first investigations. Mind you, ECG is not diagnostic in any way of heart failure, but it's a very important investigation for heart failure because it will show you the rhythm. Okay, so if the patient is in heart failure, the rhythm may be sinus tachycardia, or if the rhythm is supraventricular tachycardia, then this could be the cause rather than a manifestation. It could be the cause of heart failure, and just treating the SVT, the supraventricular tachycardia, may improve the patient condition. The rhythm may show rapid atrial fibrillation, and again, rapid AF can push a compensated patient with heart failure to a state of decompensation. Okay. The rhythm may show bradydysrhythmias as well, like complete heart block or severe bradycardia, and in these cases, the bradycardia should be treated either by medication, and you will have this on a separate lecture, or by inserting a cardiac pacemaker. The ECG may show chamber enlargement, and this is particularly true if the cause of heart failure is hypertension, or aortic stenosis, or probably aortic regurgitation, etc. Ischemic changes like an old or recent myocardial infarction. This is again can very often seen with heart failure. You remember we said the commonest cause nowadays of heart failure is ischemic heart disease. So if this is the case, then you will see the changes of ischemia on the ECG. Now, the second investigation, which is available for you, is the chest X-ray. This is a chest X-ray of a patient with heart failure. You see the left border of the heart, just look to the arrow. The left border of the heart, in this case, is bulging to the outside. Normally, the left border of the heart is straight. Okay, this is number one. Number two, you see the lung here is congested. Okay, these are veins coming out of the hile. This is the left hile, and this is the right hile. Okay, these big veins coming out of the hile and fading away towards the periphery, we call them Kerley A lines. Okay, and by the way, I usually have a separate lecture on X-ray of the heart, X-ray of the lung, and I'll go in details of these. Look to this second X-ray. The X-ray on the left is a normal chest X-ray. The X-ray on the right, okay, is for a patient with heart failure. Again, you see this left border of the heart is bulging to the outside in comparison to this left border of the heart, which is straight. You see this bit of the lung is congested. You see these veins are bigger than normal. The caliber of these veins are big. They are coming out of the hile and they fade away towards the periphery. As I said earlier, we call these Kerley A lines. You see this side, the corresponding side of the normal lung, there is no congestion. Okay, this is Kerley B line. You remember I said Kerley A lines are veins coming out of the hile. Kerley B lines are lymphatics. Remember this, please. Kerley B lines are lymphatics. Usually, you see them on the border, on the outer side of the lung. They should touch the border. If they don't touch this line, the border, then don't call them Kerley B line. And they fade away towards the center, contrary to Kerley A line. Okay, Kerley B lines are diagnostic of heart failure. Diagnostic of heart failure, I'll say it again, they are lymphatics. Kerley B lines, Kerley A lines are veins. Okay, in this patient, the mediastinum is widened because of heart failure, and this blue arrow points to Kerley A line. You see the vein is very wide and it fades away towards the periphery. Okay. This is actually a lateral view of the heart. What you see here on the lateral, this is the sternum. This is the sternum. What is against the sternum from the heart is the right ventricle. And normally, the right ventricle occupies 1/3 of the sternum. So if you see that the heart shadow comes till here, this means that there is right ventricular enlargement. The left ventricle, on the other hand, this is this X-ray on the left showing left ventricular enlargement. The left ventricle enlarged towards the diaphragm. It covers the diaphragm. Okay. Here on the right, there is a bit of a pleural effusion as well. There is some fluid in here, and this often occurs due to congestion. Okay. This chest X-ray, this is indicates it shows another abnormality in heart failure. This is acute pulmonary edema. I did tell you earlier that I'll show you a chest X-ray of a patient with acute pulmonary edema. You see the wires here. The wires here indicate that the patient is in the ICU. So the patient is critical. You see this bit of the lung is congested. This bit of the lung is congested. This is often called butterfly. You know what's a butterfly? Butterfly is an insect with very small body, but very big wings. Okay? This is the patient which is often seen in casualty gasping for air. Okay? And it shows this chest x-ray. Of course, here you can see the heart is enlarged, although this is an urgent chest x-ray. And on urgent chest x-ray, the patient, the x-ray may be taken not in a full inspiration, as usually it should be in a full inspiration, so the heart may look bigger than normal. Okay, this is a CT scan showing congestion of the lung. You see, this is quite difficult for you, but if you familiarize yourself with a normal CT scan, you will know that here the lung is congested. What is the other investigation? The echocardiogram. So remember, we started with investigation. We talked about ECG, chest X-ray, now echocardiogram. The echo is a standard and very important investigation in heart failure. Many information you can get from the echocardiogram. First of all is chamber size, okay? And the diastolic size can be measured, the end systolic dimensions can be measured as well, okay? The echo may show left ventricular hypertrophy. Left ventricular hypertrophy can occur if the cause of heart failure is hypertension, or if the cause of heart failure is aortic stenosis, then the left ventricle, because it will contract against resistance, then the left ventricular wall will hypertrophy. Left atrial enlargement may be seen, because if the left ventricle cannot take all the blood coming from the left ventricle, then the left ventricle will enlarge. Okay, the echocardiogram can measure the ejection fraction, and this is a very important measurement in heart failure. If the ejection fraction is less than 45%, then there is systolic dysfunction. If the patient is in heart failure, but the ejection fraction is more than 50, then this is diastolic dysfunction. Okay. The echocardiogram is accurate in diagnosing heart failure when the ejection fraction is low, but there is 5 to 15% of patients with heart failure have a normal echocardiogram. Okay, so the echocardiogram again has its limitations. The other thing which can be seen on the echocardiogram is the valves. You know, there are 4 valves in the heart, and all these 4 valves can be studied to a good degree by the echocardiogram, and wall thickness as well, and motion abnormalities can be seen on heart failure. What motion abnormalities? Sometimes a condition called ventricular aneurysm can occur as a complication of a transmural myocardial infarction. In this case, the left ventricle, you know, normally the left ventricle contracts like this, but if there is an infarcted area, then this infarcted area is dead, fibrotic, so it will not move normally with contraction. This can be shown on the echocardiogram. The other investigation is the blood markers. Okay, there are many blood markers, but the most important and the one which is available in our hospital, in Prince Hamza Hospital, is the B-type natriureteric peptide, BMP. Okay. Actually, this is the most consistent investigation for heart failure. Okay. If the BMP is below 100, then this indicates that the patient is not in heart failure. If the level is 100 to 300, this is suggestive of heart failure. If it is above 300, then it indicates a mild degree of heart failure. If it is above 600, it indicates a moderate degree of heart failure. If it is above 900, it indicates severe degree of heart failure. I said earlier that this is the most consistent because if you go back to the beginning of the lecture, we said that the patient may be asymptomatic. The ECG may be normal, the chest X-ray may be normal. Then we said in 5 to 15%, the echocardiogram may be normal, but the B-type natriureteric peptide is always abnormal in heart failure. Okay, so the most consistent is this. I'll say it in another way. If the patient is asymptomatic, but probably he is hypertensive or he had a history of old myocardial infarction, the ECG is not specific of anything or just showing an old myocardial infarction. The echocardiogram is with the normal limits. The chest X-ray is with the normal limit, but the BMP is above 300, then this patient is in heart failure. Okay, I will say it again, even though all these investigations are normal and the patient is asymptomatic. Okay. The treatment of heart failure. Okay, you can see here treating the underlying cause, and this is a general principle in medicine. Whenever you find any condition in cardiology or in other branches of medicine, then if you can treat the underlying cause, then you should do. Okay, actually, I should have said earlier that heart failure is not a disease entity by itself. A heart failure is usually a manifestation of another condition like hypertension, diabetes, ischemic heart disease, etc. So any one of these, if you can treat it properly, plus some specific treatment for heart failure, then if you do this, then you have done your goal. The second point in the treatment is lifestyle changes. Okay, and this is very important actually in heart failure. If the patient is overweight, he should reduce weight. And if the obesity is a gross obesity, then you should advise bariatric surgery. Okay, if the patient is 150 kilogram, don't expect that this patient will lose weight just by dieting. This is very difficult. A patient can lose weight, can lose 3 or 4 or 10 kilograms by dieting, but a gross obesity cannot be treated in this way. So first of all, advises diet modification, exercise, but not heavy exercise, okay, and bariatric surgery. Exercise is important, okay, eating a healthy diet is important. If the patient is a smoker, he should quit smoking. If he drinks alcohol, he should stop drinking. Limit the amount of coffee you take. Reduce stress if possible. keep a track of symptoms and report any change, and have a regular checkouts and monitoring. What a drug treatment is used in heart failure? I want you to remember this slide, and you should memorize this slide by heart, and I'll tell you why. This is, believe me, a very common question in the exam, particularly in the oral exam. Okay, so I want you to remember these drugs by heart. Okay, the drugs which are used in heart failure do two things. First of all, they relieve symptoms, and second group of drugs are associated with a prolongation of life. والأعمار بيد الله. Okay, and please remember what drugs are meant to relieve symptoms and what drugs are associated with a prolonged life. Okay, and you should plan your treatment accordingly. The first set of drugs are angiotensin converting enzyme inhibitors, ACE inhibitors. These are probably the most important drugs used in heart failure. There are short-acting drugs like captopril, and there is long-acting drugs like lisinopril. Okay, and all of them by many studies approved to prolong life in heart failure. Remember that these drugs are hypotensive as well. Actually, when they've introduced in medicine for the first time in the late 70s of the last century, the main treatment was to treat hypertension. But years later, it was found that these drugs are very helpful in the treatment of heart failure as well. The second drugs are the angiotensin 2 receptor blockers. Okay, we call them the ARBs. These works on the second, if you remember the renin-angiotensin system, if you remember your physiology, if a kidney gets ischemic, say if you narrow the renal artery, then the kidney will start secreting renin to elevate the blood pressure, and this will activate angiotensin 1, and this will be converted to angiotensin 2, and this will convert it to aldosterone, and this is the cycle. Okay, so we have these drugs. The ARBs are protective to the cardiac muscles as well, probably as much as the ACE inhibitors, but the ACE inhibitors are the first line of treatment. Why do we use the ARBs then? If the patient develop side effect to ACE inhibitor, and the side effect which is common here is cough. If the patient start coughing, a dry cough, and the patient is on ACE inhibitor, okay, you should stop the drug, because if you don't stop the drug, things will get worse and the patient may develop angioedema. Okay, this side effect is much less common with the ARB. Okay, but it is possible. It is not impossible. Okay, so this is the second sort of a drug. Is there any indication that you put the patient on both the drugs? No, it should be one of them, either the ACE inhibitor or the ARBs, but not both of them together. Then the other set of drugs are the beta blockers, and I hope that you are familiar with the beta blockers from your pharmacology. Beta blockers are drugs which are associated with prolongation of life in heart failure as well. Okay, probably the best protective beta blocker which is studied is metoprolol. Okay, but any beta blocker will do, and you should familiarize yourself with the side effects of beta blockers. I'm not going to go through this now. The other is digoxin. Digoxin years ago was a cornerstone in the treatment of heart failure, but then it was found that if the patient is in sinus rhythm, then digoxin may help in the treatment of heart failure for the first few months. But then if you taper digoxin gradually and stop it, then the cardiac function will not deteriorate. Okay, so if you start your patient on digoxin with the onset of heart failure, try to reduce the dose of digoxin after 2 to 3 months and then stop digoxin unless the patient is in atrial fibrillation. If the patient is in atrial fibrillation, then digoxin is the most important drug in this respect. The other group of drugs are the diuretics, okay? And you know, the loop diuretics and the thiazide diuretics. Again, you should be familiar with these from your pharmacology. These drugs are not associated with a prolongation of life, but they are very good on relieving symptoms. Okay, and a loop diuretic like furosemide intravenous is a standard treatment when the patient is in acute pulmonary edema. Okay, but then you should optimize the dose of diuretic. And what do I mean by optimize? I mean that you reduce the dose of diuretic to the degree that the symptoms, the shortness of a breath is relieved, but don't overdose your patient, because if you overdose your patient with diuretics, okay, then you will deplete fluid and you will reduce the cardiac output. Okay, so a small dose of diuretic is usually very helpful. It relieves the shortness of a breath, but don't overdo it. Don't overdose your patient. A blood vessel dilator like the mono and dinitrates are again a standard treatment, and they are associated with a prolongation of life. Potassium or magnesium sometimes used. Aldactone inhibitors again are drugs which are associated with a prolongation of life in the treatment of heart failure. There is a very important drug. I'll talk about it in a few minutes, because it's another drug which is associated with a prolonged life. And this drug here is ivabradine. Ivabradine is a drug which causes AV block. So it reduces the rhythm of the heart, okay? And it's indicated if the patient cannot take a beta blocker, okay? So if the patient cannot take a beta blocker, because beta blocker do the same, do AV block, then this is a standard antihypertensive medication. Okay. In the recent years, okay, it was found that, I beg your pardon, it was found that a combination of an ARB and an aprillicine, okay, in a 1-to-1 ratio, okay, is associated with a 20% reduction in the mortality of heart failure, okay, significantly, 20%, okay. This is a drug originally called LCZ69, LCZ69. And the trade name which is available is Entresto. Okay? It's the combination is this one, valsartan, this is an ARB, okay? And sacubitril is an anaprylizine. In 1-to-1 dose, okay, we will have a drug which is called LCZ69 or Entresto, okay? This is an expensive drug, but the studies have shown that it reduces mortality by 20%. So I'll say it again, please remember all drugs which are used in heart failure, remember drugs which are associated with prolonged survival, and remember the drugs which relieves symptom only. Sometimes patients develop anemia due to heart failure, okay? And this anemia should be investigated for a cause like iron deficiency or folic acid deficiency or B12. If there is no cause for this, then this anemia should be treated with erythropoietin and injectable iron, okay? Again, this may improve the patient's condition. This is a certain group of patients, I will say it again, a certain group of patients with heart failure may develop anemia, not all of them. If the anemia is due to iron deficiency, correct the iron deficiency. If it is B12 or folate, again, correct the deficiency. But if the anemia is solely because of heart failure, then it can be treated with erythropoietin and injectable iron, and usually the patient's condition will improve. Okay. I have already said what's written in this slide. And this is the Entresto I told you about. It's LCZ696 Entresto. Okay. And we have seen this. Remember this drug, please. Okay. Thank you very much.